topics I could focus on at a later date, and I'm happy to chat. I basically love to chat about anything to do with MRI, but what I wanted to do today was actually talk about biliary imaging, and specifically, I think the concept of an MRCP, which you guys get all the time, and I do MRI, and I'm going to focus on that, is a little tricky because I think it's not always clear exactly what we mean when we say MRCP because it can actually refer to a couple different things. And so what I wanted to do was actually chat a little bit about how we approach biliary imaging, particularly with MRI. Um, and um, and I spelled gastroenterologist wrong. And anyway, and then really talk about some pitfalls and really give you some examples of what we can see and what we can't see. Because I think the reflex is really anything if someone has a high bilirubin or something like that is really to get an MRI, even if we already have a CT or something like that. And really often, if one is normal, then the MRI probably isn't going to show anything. So with that, I'll do that. And like I said, I think there are other topics, there's like quantitative liver imaging and there's like, Crohn's disease and all those other things. And I'm happy to chat about it at another time. So basically what I'm doing here, anyway, for people who don't know me, I'm Mike Ohliger. I've been at UCSF now probably about 14 years. I started as a resident. I did my fellowship here and I'm an abdominal radiologist and I work, I split my time between UCSF and San Francisco General and I have a modest research program as well. I'm also the director of MRI for UCSF, and so I have just a sort of a soft spot for MRI. I went into abdominal radiology a lot because I really loved the diseases of the GI system. And so, and also just love the relationships and the interactions that I get to have with gastroenterologists. And so I'm really happy to chat about this and really any questions. And then as you come through the hospitals and other things, I'm happy to chat. And so actually this is part one, but actually I realized that this was a really big topic. This was only going to be part one of many, but I realized we're going to leave it as part one because I think it was enough to fill up the hour. What I'm going to do is actually talk a little bit about methodology, not really basic MRI physics, but really when we approach MRI of the biliary tree, just to point out that, like I said, it's not just one thing. And depending on how we do things, we can see things sometimes and we can not see things others. And I'm just going to show you some examples of, biliary pathology that you might be interested in in your experience and just as another experience on this. And so first, I think I'm just going to start, right? So basically MRCP, so it's the magnetic resonance cholangiopancreatography. And one thing I'll just say at the outset is I'm not going to talk about the pancreatography part about this, but really it's an MRI technique in which we can actually see the bile ducts and the pancreatic duct, and we can see them both really well. And actually it's something that MRI does extremely well, and that's because MRI sees fluid really well. Like basically, there's a couple things that just, if you said, okay, what was MRI invented for? One was to distinguish fluid from not fluid, because you can see here on a T2 weighted sequence, the fluid is really bright and everything else is dark or not as bright. And then the other thing is to actually separate fat from not fat. And we could talk about that. If you ever want to talk about fatty liver, I'm always happy to talk about that. And that's another, and I'd say those are the two things that, if you had to say like, oh, what is the wheelhouse of MRI? And those are the two things. But in any case, the main uses of MRCP, as you know, is actually to look for the biliary pathology, and often those are going to be stones and masses. Now, of course, there's more biliary pathology than just stones and masses, but really, when we're talking about things like inflammatory processes or cholangitis, things like that, that tends to be like abnormal enhancement and thickening of the biliary tree. And really, when we say, okay, well, when you order an MRCP, we're really actually adding a sequence that looks at the lumen. So those other things don't really affect the lumen of the bile ducts. And so we see them with just a normal MRI. When we do MRCP, which is actually kind of cool, we don't actually need contrast for the MRCP part. But we usually do this as a contrast-enhanced examination because sometimes patients will have masses. They're going to have biliary thickening. Maybe they'll have an enhancing mass in the common bile duct, like a tumor or something like that. And so that's why whenever you order an MRCP, it's usually MRI with MRCP, just because historically how they've been sort of developed is that MRCP was always considered a separate exam. And that's really actually for historical reasons. I mean, usually if you just said MRCP, it should go without saying that you would do an MRI, but that'll be important maybe other places that you go. So UCSF, we don't do MRCP without a liver MRI. So it's if you order MRCP, or if the primary team orders an MRCP, but they don't order a liver MRI with it, usually it prompts a phone call because we want to see what's the full anatomy for a liver MRI. But actually, at other institutions, that's not true. And so you'll definitely work in places where if you say MRCP, basically you get a view of the lumen of the GI of the biliary system, but you don't get a view of anything else around it because you just get the MRCP part. So one thing I'll just talk about what it's good for, and here ideally actually we would have images, and I think in a future version we will. But I do want to just briefly talk about ultrasound, CT, and MRI, because ultrasound and CT are actually obviously really good modalities. And to be honest, like if someone comes into the emergency room with abdominal pain, or if you're just working someone up with an initial acquisition, you're going to start with ultrasound or CT. You're not usually going to start with an MRI. And so it's good to think about what they're good for. So ultrasound really, again, what it specializes in, and really what there's really not much comparison to, is actually for assessment of the gallbladder. It's probably the best thing we have for assessing the gallbladder, except in patients that are too large or something like that. It might even be better than MRI because you can actually move the probe around and you can kind of look around and do things like that. And you can see really tiny stones. So actually stones, because you're interacting with sound waves and you're causing shadowing, ultrasound is really great at seeing stones. And that would be really the end of the story, except for what ultrasound does a really bad job at is actually seeing the common bile duct, because the common bile duct tends to disappear behind bile gas as it comes through into the ampulla. And of course, we always measure the common bile duct at MRI, I'm sorry, in ultrasound, but when we're measuring the common bile duct in ultrasound, we're measuring it in the porta hepatis. We're almost never looking at the distal common bile duct. And really the ability to see the distal common bile duct and identify obstructions is really why, is where you want to move on from ultrasound to something else. Now, CT is actually very good for the biliary tree. It's maybe not as good as either ultrasound or MRI, but doesn't mean it's bad. And in fact, when most patients come into the emergency room, for instance, with abdominal pain, or they have an elevated bilirubin or something like that, CT is usually the first diagnostic choice. And actually, it sees the gallbladder very well, and it sees the ducts very well. Maybe not in quite as much detail as either ultrasound or CT, MRI, but it does a fine job. The Achilles heel of CT is stones, and I think you've probably seen many examples of that. So if a stone happens to be radiopaque on CT, which is probably about 60% of stones you can see on CT, but actually there are about 30 or 40% of stones that you can't see on CT, and you'll just like see it and you're just like, this looks like there's nothing in there, and you'll do an ultrasound and say this whole thing is full of stones. When you're doing MRI. And I'd say that that's actually where CT falls apart, is really if there is a question if there's an obstructing stone. We'll get to MRI, and really, and again, I'm biased, so I should have put that in my disclosure, is that, I'm a huge fan of MRI, and it's what I've done, for most of my career. And the sort of goal at the end is MRI is actually great for all of this stuff. It's a little expensive, it's a little hard to get. And sometimes it can take a little bit of time to acquire, but in terms of diagnostic ability, looking at the gallbladder, the bile ducts, the stones, the tissues around it, it's really exquisite, and there's really nothing better. But what I want to just comment on here, and I think there is this idea sometimes when people are ordering studies, that if something is not the best study and we don't know what's going on, we go to the next one. And it's true, MRI is definitely better than CT, but if a CT is totally normal, and we actually get this all the time, not usually from GI, but many times from other services, is we'll get a study where the CT is totally normal. The bilirubin happens to be elevated or something like that, and then we get an MRI, and it's very unlikely that an MRI is going to show something if the CT is totally normal, because again, you're looking at the same anatomy. Now, the other way around, if a CT shows an abnormality, MRI can often clarify it. But really, if one is totally normal, the other one is not necessarily, with the exception of the fact that if what you're looking for is stones, we can see stones extraordinarily well. I would also just say stop me at any time if you have questions. Now, before I get to just talking, we're going to talk about MRI, MRCP and the biliary tree for a long time, maybe 20 minutes or so. Before I talk about that, I just want to talk about a little bit, just give you an introduction to when we say we do a liver MRI, what do we do? Now, because it's like, what do you get with your package? It's like you're buying a car and you're like, well, what comes with the base model? And really, the routine abdomen, as we say, or the routine liver MRI, which are basically the same examination, is actually a fairly comprehensive examination. It takes about 45 minutes to do. We usually do a portion of the exam with contrast and a portion of the exam without contrast. And you may know these terms, T2 and T1 weighted images. It's not important too much to know them. The key is to think about is T2 is very sensitive to water. But it's also basically what we use to look at anatomy. So like, for instance, we have a coronal T2, which is basically, again, technically a water-sensitive sequence. You don't really have to know that. But when you see this, you're like, wow, this, you can see the liver, you can see the bile ducts. If I come, sorry, that's the colon. If you come a little bit more anterior, you can actually see the kidneys extraordinarily well. You can actually see the aorta. So for looking at anatomy, basically, you know, what's there? Is anything obstructed? Is there anything wrong? Really, this T2, which as you look through our exams, this T2 without fat saturation is really going to be your friend. The fact that you see the fat allows you to sort of delineate image planes. So really, the most accessible image is actually going to be this. Now, how is this acquired? This is a T2. It's called it's basically, you do multiple breath holds, and each slice takes about 100 milliseconds. And they'll take like 3 breath holds. And so this total image probably takes about 2 minutes because you're going to do 2 breath holds, 3 breath holds. Now, the other one, the sort of Achilles heel of this T2 weighted image without fat sat, which is where you see all the fat, is actually looking at lesions. You can sometimes see small lesions, which are T2 bright, on this, but many times you can't. And that's a little bit because of the physics of the way this is acquired. So we'll have another acquisition, and you'll see this as you look at it, and it's almost always with fat saturation, and it's T2, and it's in the axial plane. And every institution, every MRI protocol for liver is going to have this. And really, there's 2 purposes here. One is that you can distinguish fluid, ascites, from fat. So the fat is bright and fluid is bright without fat saturation. But when you do fat saturation, you can see ascites fluid. And also, you can see tumors or lesions within the liver, and sometimes other organs a lot better than you can see when you do it without fat sat. And so that's just something to come in, and I can give you some examples at some point. And we can talk about the regular liver MRI. There's another one which is part of another lecture, which is what's called a T1 weighted image. Now, the T1 is used for 2 things in the abdomen. The first thing, which is I'll get to afterwards, and that's the obvious thing, is I actually can look at how things enhance with contrast. So if you have really tumors or lesions or vessels or anything, and I give contrast and I want to see how they light up, that's going to be T1 weighted imaging. Now, there's one other use of T1, and this is before I give contrast, and that's because I can make 2 images which relate to fat. And I can make one image where the fat and water in the liver, for instance, is out of phase with each other, which means that the image is basically fat minus water. And I can make another image in which the fat and water are in phase with each other, and that's basically fat plus water. And this helps me diagnose liver fat usually, but also fat in other organs like adenomas in the adrenal gland. Not as interesting to GI. And then the last part, of course, is the postgadolinium. And this is, of course, the workhorse of what we do, especially for things like surveillance for hepatocellular carcinoma. This person actually has a funny lesion. Actually, this, I believe, ended up being a cholangiocarcinoma. It's this lesion that has this ring-like enhancement and progressively fills in. And that actually has, a very high association for ending up being cholangiocarcinoma. The interesting thing is it's a mimic because that can also be a hemangioma if it enhances a little bit more differently. But again, that's a little bit beyond this talk, but we can come and talk about that on a different day. The last thing also, which I'll talk about a little bit, is actually diffusion. Diffusion is again, I think, a topic for a talk by itself. But this is actually a way of actually seeing whether water molecules are confined to a tight space. So in tumors, for instance, water molecules are confined to a tight space because the cells are all packed together. Similarly, when you have an infection, the water molecules are all confined to a tight space. Whereas if you have normal water that has less what we call restriction on diffusion, it's not. And so basically we do special things so that when something is confined to a tight space, for instance, this lesion here, it ends up being bright. But I wanted to just give this as an idea when I talk about biliary imaging, because first of all, when we talk about MRCP and how to do it and what it can do, it's all placed on top of this, which is our standard liver MRI. And this, again, already does a lot. And then there's a lot that you can do with this. The total time for this scan is about 40 to 45 minutes. And so, and basically gives you really all the information that you can possibly ask about for the abdomen. Cool. If there are any questions about the regular liver MRI, I'm happy to talk about it. Good.
Can I ask a
Yeah.
quick question?
Yeah.
Just in regards to earlier when you were saying like when to choose CT versus MRCP, etc.
Yeah.
What are your thoughts on like CT pancreas versus MRCP if we're just trying to look at the pancreas duct and areas?
Yeah. And I should have included more pancreas here. So this just to talk about MRC, to talk about the pancreas for a second. So there are three things for pancreas that we can talk about. We've got CT pancreas, and we just have a regular abdomen CT. So we can talk about what's the difference between a pancreas CT and an abdomen, just a regular abdomen CT. And then the second thing we can talk about is what's the difference between a CT pancreas, abdomen CT, and an MRCP when looking at the pancreatic duct. And again, and like I said, I think we have plenty of time for this overall talk, so happy to chat about any topics. And so basically, the first thing to know is that when you talk about pancreas protocol CT, some people think that it's really for anything that has to do with the pancreas. So it's like, oh, I wonder if there's pancreatitis. Let's do a pancreas protocol CT. And it really isn't that. It's actually a very specialized examination. And it's for a patients in which you have a very high probability that there's pancreas cancer. And that's actually the real one and only reason that you're going to do a pancreas protocol CT. And the difference between a pancreas protocol CT and a regular CT is that you have an extra phase of imaging, and that extra phase of imaging tends to look at the blood vessels a little bit better. It also, when you have a tumor, can sometimes give you better contrast between the tumor and the pancreas itself. And so the blood vessels is important because that's actually part of pancreas cancer staging. You want to see the relationship to the blood vessels. And then the other reason why that it's important is because, again, if you think if you think that there is a tumor, then you can see it. Now, looking at the way you usually diagnose pancreas cancer or you assess the pancreatic duct is through dilation of the pancreatic duct. And actually, CT can see the pancreatic duct really well. And it usually sees a dilated pancreatic duct very well, whether it's a benign cause or a malignant cause. And so that's actually pretty good. Now, so the pancreas protocol, unless it's really for cancer staging, essentially, is just extra radiation, especially in someone with pancreatitis or something else. It rarely adds anything. Now, we can talk about an MRI. Let's say someone has a dilated pancreatic duct and you don't know why. So MRI is usually a good second step when someone has a dilated pancreatic duct on CT scan. And that's for a couple of reasons. Sometimes you can actually see lesions in the pancreas, masses in the pancreas, a little bit better on MRI than you can on CT. So if you see an abrupt, termination of the pancreatic duct and you want to know, is there an underlying mass? MRI is really good for that. It's really good for actually seeing if there are stones or other things obstructing the pancreatic duct. And it also is really good for details of pancreatic ductal anatomy. So in CT, you don't necessarily see every branch. You don't necessarily see if someone has pancreas divisum, although many times you can. And so these sort of high resolution details of pancreatic anatomy is where it can help. And so I think those are really the two main uses. Where you have a tough time is, of course, if you have an abrupt termination of the pancreatic duct and you're like, oh, someone has cancer. You know, whether you see something on the MRI or not, you still worry that someone has cancer, and that usually requires an endoscopic ultrasound. And so I hope that helps. And yeah, I think for the next version, you know, I'll make sure I emphasize the P part of the MRCP as well. But yeah, I'd say that the key one of the take homes I think is that we can actually see a lot on a regular CT. CT doesn't get a lot of respect, but the key is that pancreas protocol CT again really it's where there's a high suspicion for pancreas cancer, and again otherwise you're kind of just for the most part giving extra radiation for not much benefit, and then for you know, I think MRCP versus the MRI again it's really for looking if there are masses or other things that you can see that you can't see on CT. Now, the advantage of CT is that the spatial resolution of CT is much higher. So for things like pancreas cancer staging, CT is always better because you can see the blood vessels a lot better. Hope that's great.
Mike,
Yeah.
quick question.
Yeah.
I've been told that a CT with pink protocol is about 4 times the amount of radiation as a regular CT. Is that accurate?
It depends how you do it. I think it's just you know, the radiation goes with the number of phases that you do. So standard pancreas protocol has you acquire 3 images. You acquire a non-contrast image, you acquire what we call a pancreas phase image, and we acquire regular portal venous phase. So by default, it's 3. Some people acquire 4. Actually, at UCSF, we acquire 4 phases. And I could talk sometime why we do the 4th. Yeah, and so there's about 4, I think 4 times is probably a good rule of thumb number, but you know, the amount of radiation is really just related to the number of contrast phases you acquire in CT. Exactly. Great. Good. Cool. Excellent. So again, I'm happy to talk about pancreas at another time, actually, 100%. Okay, so what I want to talk about is just biliary imaging now, and we're just going to focus on the bile ducts. And the reason I like to go over this, and I do this for our residents too, radiology residents too, is because really when we look at the bile ducts and we look at an MRI, we actually have several approaches that we can do. And what I can say is when there are 2 broad classifications, one is this non-contrast, what we call T2 weighted or fluid sensitive, because you're seeing fluid in the bile ducts, approach to looking at the biliary tree. So you're relying on the fact that without giving IV contrast, fluid is just bright. And we actually have 3 methods of doing that, and I'm going to talk about each of them in a second. And we can say whether, and I'll talk about what each of these mean. And then the other method of doing it is actually giving contrast. And there is a contrast which I think most of you probably know of. And it's a special MRI contrast. It's called Eovist. And Eovist is taken into liver cells and is excreted into the biliary tree. And so it's really good at actually seeing the bile ducts, and it's very similar to like what HIDA does. In MRI, if you know about any contrast agent, you should know about, as a gastroenterologist, you should know about Eovist, because this one comes up a lot, and it's all the other contrast agents are basically the same. And so this is the only contrast agent that does something like this. But I have a separate section on that. And so I'm gonna talk about each of these in the middle. And so the first thing is just what I call a regular T2. So again, if you're looking through, and I encourage you to look through the scans of your patients, this actually is the same scan I was talking about that's part of a regular MRI. This isn't even really an MRCP, but actually you actually see the ducts actually really well in this scan. You can actually see the common bile duct here, which is right there. And you can actually see those little 3 circles down there, which are actually stones, right? And they're like little layering stones. And then here's all the little cute little gallstones in the gallbladder. And so actually we can see the stones, we can see this. And again, we didn't even order an MRCP, so you wouldn't need an MRCP for this. This is just, you know, regular T2 weighted imaging. Now, the disadvantage of this is it's prone to artifacts. And I'm 100% sure that you've seen one of our reports where we said, well, there's a little thing here. And you see this little black dot. That's actually in the middle of the duct, right? It's not layering dependently. And so I'm thinking this might be a flow artifact. And you say, well, we see a little tiny dot. This could be a tiny stone. It could be an artifact. And so this is actually a limitation of this type of thing. But the great part of this is, again, this is included in every MRI scan of the abdomen you get. And so we can actually see this. But really, a lot of times, especially looking for stones, as opposed to looking for like other obstructions, requires confirmation on another sequence. Now, I'm going to transition to what is classically referred to as an MRCP. Now, we use fancy names for it, but all it really is it's a separate setting on a regular T2 weighted sequence. For people who know a little bit about MRI, there's something called an echo time. You don't have to worry too much about that. But suffice it to say, if you do a regular T2 weighted sequence, you see all the background tissue. And if you do a modification to your parameters such that you suppress everything except for the fluid, that's actually what an MRCP is. And so actually we see we've suppressed, well, we have the biliary tree, but it actually looks a little bit ugly because we have a lot of contamination here with the stomach and the duodenum and other things. And a lot of times the MRCPs that you see, they've actually been edited so that we actually cut this part out and so that you ignore everything else. And so that's why it looks good. But really all you're doing is you're taking a T2 weighted sequence and you're making it, and you're giving, changing the parameters so that you accentuate things with a very long T2 or you accentuate fluid and you suppress everything in the background. And that's it. And so that's where the liver and that's where the liver, spleen, and the portion of the stomach used to be. And so that separates background tissue. And so one of the things we can do is we can actually do things to actually further suppress the background tissue. And one thing we do is it's the one exam where it's really important to be NPO. So we ask people to be NPO 4 to 6 hours because that removes a lot of the fluid in the stomach and also removes a lot of the fluid in the duodenum. And this is an MRCP. Actually, this patient actually has a pancreatic cyst here. But then we can actually give things, and it's actually, believe it or not, it's pineapple juice. So there's other juices you can give that actually decrease the signal in the GI tract. So many times we'll give patients pineapple juice in order to see this. So here's the patient with duodenum there. And then basically we're like, oh, I don't like having the duodenum in my MRCP. Here's the pancreatic duct and the common bile duct and gallbladder. And so I can give pineapple juice. And you see here the signal due to that in the duodenum just disappears. And actually I have a much better image of the distal common bile duct and the distal pancreatic duct. You can use pineapple juice. You can actually use blueberry juice because they have metal ions in them. And then there are people developing more sort of pharmaceutical grade versions of this, which of course are going to be more expensive. The problem with pineapple juice is different pineapple juices, because they have different metal ion contents, will be more or less effective in doing this. But we just give whatever the hospital has for pineapple juice. But this is actually a really nice way to clean those things up. Now, one thing we can do is what we do is actually this one I think is most familiar to patients who, I'm not patients, sorry. This will probably be most familiar to gastroenterologists. So basically we do what is the same physics or the same projections as an ERCP, but we do it with MRI. So what we'll do is we'll acquire a very thick slice, and we just basically collapse everything in this slice to a single plane, right? And so, for instance, this is actually a patient with PSC. You can see the bile ducts look kind of ugly. And so what we've done is we've excited a very, very thick slice, and we just have collapsed everything to a single plane. So that's really exactly the same, except for the fact that, if you give dye and then you take an X-ray with a single projection through the biliary tree, and everything gets collapsed onto a single plane. And so this probably looks the most like an ERCP. And what you do is you do one projection, and then what you do is you just keep rotating that plane around, and you get different projections that you can then see, right? Now, the advantage of this is each of these planes is really fast. It's, again, about 100 milliseconds. And so if you hold your breath, you actually can't do them right after each other, but you can do about 4 of these at a time when you hold your breath. And so it's very fast. and it's reliable if patients hold their breath. Now, and actually that's very nice. Now, because it requires multiple breath holds, it actually takes more time than you can think. It takes probably about 5 minutes to do this whole thing. And then because you're doing a projection, right, everything is collapsed on top of it, you can miss small stones. But for getting a nice view of the biliary tree, this works well. And again, as you look through the scans of your patients, you're going to see this one. Sometimes it's labeled 2D, sometimes it's labeled radial because, or wagon wheel, because you can see the thing, the image plane rotates around like this, okay? And that looks very ERCP-like. Now, we have a second acquisition, which actually has a higher spatial resolution, but takes longer. And so what we do here, and you can see there, is we acquire a full volume of very thin slices, right? And you can see this patient, again, with, I think also this patient, a lot of patients here have PSC. And basically, we do all of these very, very thin slices, and we acquire a full volume. Now, this takes a long time. So this takes about 4 or 5 minutes to acquire because the slices are so thin. And because nobody can hold their breath that long, we actually do something called respiratory triggering, which means that there's like basically we monitor how patients are breathing, and when they breathe in and then they breathe out. Once they breathe out during that acquisition, we acquire data. They breathe again, we pause, and then we only acquire data when their breath is in the neutral position. And so if someone breathes regularly, which is really great, that's actually usually outpatients, something like that, these tend to come out really pretty. Now, for inpatients, they can be a little frustrating because those patients don't often have regular breathing. They have irregular breathing, and so these can be corrupted. But that's our 3D MRCP. We usually do both because usually one will come out a little bit better than the other. And so when we have this one actually comes out really nice, and we have super high resolution scan. And you can actually make what's called a MIP. You can make a projection out of these scans in any orientation that you like. And so you can basically reproduce what you would see in an ERCP or what you would see in a, on that further 2D acquisition by doing this. And so again, the reason I think of going through there is because it's good just to see, like you'll see a whole bunch, like when you open up the scan, you're just going to see a whole bunch of things that look like the biliary tree. And that's because we've done it a lot of different ways. Now, one of the pitfalls of this is that we have these MIPS. They're actually really quite beautiful, and they're great for talks. You can actually see the common bile duct, you can see the cystic duct, you can see really the branching of the biliary tree, all this stuff. There's actually a duodenal diverticulum there. But what you can do is, again, because you've averaged through them, you can miss very small stones. And so for looking for stones or other small filling defects, I usually will look at these very thin original slices. And actually, you can see there, I'm pointing at it, but you can't see me point, of course. And I will just go to the right slice. And you can actually see here in the distal common bile duct, these tiny stones. But if you just looked at this image, which is the same image, it's just averaged through, you would miss those stones. So again, this is just to give you an orientation as you look through the scans of your patients. And so we can miss small stones that way. So I'm going to show you a couple interesting ones. So this is, again, this is for more, I think, as radiologists are doing interpretation. So this is for an example of someone who looks like they actually have a filling defect in their common bile duct. Now, the issue here is that it looks like there's a filling defect in the common bile duct, but actually the proximal ducts are not dilated. So it'd be kind of weird for someone to have an obstruction here and not have dilated intrahepatic ducts. And actually, this is a case of a patient who has had a cholecystectomy. It's a very common place to get signal loss. And so where you have metal in MRI, you tend to get signal loss. And so this is metal signal loss related to the cholecystectomy clips. And so again, this is a very standard artifact. This is another cool one. And you're going to see this all the time. So for people who are on the transplant service and you look at the MRIs that we do for transplant donors, every patient that you see is actually going to have a little bit of what looks, again, like a stricture or a filling defect in the common bile duct. And actually, This is a very typical place. It's a crossing of the right hepatic artery. And so every now and then someone will say, oh my gosh, that there's like narrowing of this duct. But the key here is that you just kind of have to know where it is. But also the key here is that there isn't a stricture. There's nothing dilated proximally. And so that's something that we see very typical. And again, the reason I say we see this in the transplant donors is your transplant donor patients, because they're young and they're healthy, they're going to have the nicest MRCPs that you see. And so often you can see this very high resolution and you're going to be able to see them. Another funny mimic of a stricture, and this is actually not, this is, I think, more of an advanced topic, is this is, again, a patient with PSC. And you can see the ducts have all this pruning and irregularity. And it looks here in the left, like there are these really big filling defects, right? This is where the left hepatic duct would come along. And actually, on MRI, this is actually pneumobilia. And so this here is a T1 weighted acquisition where you can actually see signal loss where there's air. And so as you know, when someone has had a sphincterotomy, you actually get air in the biliary tree. And air in the biliary tree can cause signal loss, and it can make it look like there's a stricture. And so, again, that's something you guys all need to know, but I think it's really a nice example of how these things can be a little bit more complicated than they look at first. And that can be tricky. So again, this is air in the biliary tree, and then looking like a pneumobilia sphincterotomy. The last thing I'm going to talk about is Eovist. And again, I think going forward, if you're going to be familiar with any contrast agent from MRI as a gastroenterologist, it's going to be Eovist because, again, all contrast agents besides Eovist, which you've probably just heard about in passing as we've talked about as radiologists, work the same way. So except for Eovist, every other contrast agent, and for both CT and MRI, is what we call an extracellular contrast agent, which means that it goes into the blood vessels, it goes into the soft tissues, but it does not go into the cells. And so basically, that's what they do. And really, different companies have different patents on each one. Some of them have slightly different pharmacokinetics, but they're basically the same. The one exception, which is actually pretty remarkable, is this contrast agent called Eovist. And what's pretty cool about it is it's actually actively taken up into hepatocytes. There's a transporter, and it requires energy to do it. So it's a facilitated transport. So it basically requires, sorry, not facilitated, it's active transport. And so if you don't have living hepatocytes, it doesn't get transported in, and then it gets excreted into the biliary tree. And so there's lots of uses of this agent. So there's as part of a different talk, you can look at it to look at hepatocyte function, for instance, something like that. You can use it to detect tumors because tumors actually, like metastasis, don't actually take up Eovist. And so that's another way we can use it. But for the purposes of assessing the biliary tree, it's a great way of looking at biliary anatomy because it's high resolution. The other thing that it does really well is it detects bile leaks. And I think actually this is a really useful thing to know as someone who orders these studies, and I'll show that in a second. But this is someone who's had actually a cholecystectomy, and this is basically a normal one. You can actually see the residual cystic duct right there, boop, and it ends. This is where the gallbladder would be. But this is what it looks like. The background liver is bright, and then we get contrast excreted into this biliary tree. Unfortunately, it doesn't work quite like a HIDA scan because there's not a lot of time for this contrast to get into the gallbladder. So it does in principle work like HIDA. It's the same, actually, it's actually the same chemical that allows it. But here's an example of where this contrast agent Eovist can be really useful in looking at the biliary tree is if you're suspecting that there's a biloma or a bile leak. And so this is a patient, for instance, here, where they've actually had a cholecystectomy. This is a fluid collection in the gallbladder fossa. It's not the gallbladder. And we're wondering, does that actually communicate with the biliary tree? So you can give this contrast agent, and as you wait over time, and this is about 15 minutes after you give it on the right, maybe 20 minutes, you can actually see there's actually contrast going through the cystic duct remnant and then actually filling that cavity. And so you can identify that bile leak. And the reason it's important to know, I think, as people who are ordering it, is there is a role to actually specifically ask for this contrast agent if what you're looking for is specifically the origin of a bile leak, or if you tell the protocoling radiologist that you're specifically worried about a bile leak, they'll usually protocol it with this contrast agent. And so This has a whole bunch of different properties. People still do a lot of research on it. Again, looking at the properties of the hepatocytes, but for the purposes of the biliary tree, what you really like to see here is the fact that contrast is excreted in the biliary tree and then goes into the ducts. Excellent. There's a pitfall of using Eovist. It actually doesn't work if people have a high bilirubin. So if the bilirubin is greater than 3, it doesn't work. Here is a bilirubin of 6. And that's because it doesn't get taken up into the liver cells. And the reason it doesn't get taken up into the liver cells is 2 reasons. One is you tend to have hepatocyte dysfunction, but the real reason is actually the bilirubin competes with the transporter for Eovist. And if you have a lot of bilirubin in your blood, then you just don't get much taken up. So high bilirubin, you get no uptake or excretion. So here we go. I'm gonna the rest of the talk is going to be basically examples, but I just wanted to take a little bit of time to go over different methods that we have of looking at the biliary tree. And with the exception of this one, which is Eovist, or gadoxetate is the trade name, the generic name. This is basically, we usually do all of these when you order an MRCP. This fast spin echo, what we call, or this coronal T2, this actually comes with every scan. When you order an MRCP added, this is what you get. This is the additional part. It's this 2D and 3D. And then for some purposes, like transplant donors, and also looking for bile leaks, we're going to give this hepatobiliary contrast. There's, I won't go into details on this. So as you go through your career, there's actually more innovations on this. There's deep learning to make this faster because these tend to take longer. So this is an example of deep learning image reconstruction to make these look prettier. And you'll probably hear more about these as they go along. So we talked about MR methodology, and in the last, I guess, 10 minutes or so, I'm going to just give you some case examples. And it's going to go a little quickly. This is going to be like a potpourri of like how we can see things. Some of these are going to be tough because, you can't see, you're not used to looking at these images. I'll try and show you very quickly where appropriate. So this is actually just a classic. This is like, for radiology residents, this is like you're the first board question you'll get or something like that. And this is, again, where we would use MRCP. We have a regular, first of all, we have a regular T2 weighted image. This isn't even an MRCP. This comes with every exam that we ever do. This is the MRCP, and we see dilated left duct, we see dilated right duct, and they don't meet. And so you're really worried that there's a cancer in between there. And yes, so this is a classic appearance of a hilar cholangiocarcinoma that we would detect through an MRCP. Now, the reason this is important is for various reasons, this mass is actually really hard to see. Like if you do contrast, if you do a lot of other things, many times you can't see the underlying mass, and all you see is this abrupt termination of the ducts, and you've probably seen that in our reports. And no matter what, we're worried that there's a cancer there. And that's just a classic view of that. And I have other examples as we're going to come along. Now, on the CT, it's very subtle, but you do actually get delayed enhancement of that area, which is where that hilar, or the Plotkin tumor, the hilar cholangiocarcinoma is. So cholangiocarcinoma, as you know, is really, when we look at the biliary tree, it's the second most common liver tumor. But, for the biliary tree, this is really what we want to look at. It's got a bunch of risk factors. I want to show you the examples, really the imaging examples of how it looks like on imaging because it can be very subtle. You can have mass forming, which it looks like a mass infiltrating, and also intraductal, and I'll show you examples of those. So first, mass forming cholangiocarcinoma. This is the one that's more straightforward, where you actually see a mass. And here is, again, these masses tend to be really hard to see. You tend to know that there is because it's indirect. We see some dilated bile ducts. They all meet here. And here is this fuzzy looking thing here that is the mass. They have a very characteristic imaging thing. They will cause capsular retraction. And so you'll see that in our reports. If it's capsular retraction, which means that the capsule is indented inward, we're worried that they have a fibrotic reaction. We're worried that it's cholangiocarcinoma. And the other thing, this is actually a separate lesion. It's not the same lesion. There's a separate lesion right here. It progressively fills in with contrast. Again, it tends to be very subtle. Like it's actually not so bright, but it just progressively fills in. The reason it progressively fills in against it is because it makes a lot of fibrosis. And when you have fibrosis, the contrast just progressively fills in there. Now, if you have extrahepatic cholangiocarcinoma, like in the duct, this is actually the hardest thing to see on MRI or any imaging. Like, we have a lot of tough here. Now you see here, this is an MRCP. There's a gap. This is the proximal common bile duct. This is the distal common bile duct. And when we look at the enhancement, we actually see enhancement right there. But this is very subtle, but that's actually the mass in the common bile duct. And this is actually PET uptake in the mass in the common bile duct. So every now and then we can see the mass, but again, usually as radiologists, it's just the fact that there is a stricture makes us worried that it could be a malignant stricture. Now, one of the big things that going from malignant to benign etiologies, we look at PSC is actually really a huge use of doing an MRCP. And when we do MRCP with PSC, and you see these, it's the same thing you look for on an ERCP, is really you're looking at the biliary anatomy. You're looking for pruning, which is like abrupt termination of ducts. Beating is when they actually grow like this. And then also either short segment strictures or long segment strictures. And these findings parallel what you're going to see on an ERCP. And again, just shows you the power of what you can do on a non-contrast examination. One thing I just want to show you as a counterexample is this one, which is, this looks exactly like our Klaskin tumor, right? This is where we had our hilar cholangiocarcinoma, right? Abrupt termination of ducts, nothing there in the middle. And actually, we see the mass here. Now, this is, again, this little bit of radiology inside baseball, but cholangiocarcinomas are really hard to see. So when I can see the mass, I get a little bit suspicious that it may be something other than cancer. And this is something that progressively fills in. You still think that it's cholangiocarcinoma, and you do have to take it seriously. But especially when you can see the mass really well, I will actually think of other diagnoses. Now here, the clue to this diagnosis is actually I use diffusion weighted images. So you can use your T2 as well, but we see lesions other places. We actually see this lesion in the pancreas. It's bright here, and then it's dark there. Excuse me, something just, sorry. And then we could also look at the kidneys. We actually see lesions in the kidneys. So anyway, so the classic findings when you have lesions in multiple organs, including the biliary tree, and actually this patient came in with jaundice, but we saw these other lesions as actually IgG4 cholangiopathy. So it's always something that we have to keep in mind. In the terms of the pattern of assessing the bile ducts, it looks exactly the same. The two clues are the fact that it tends actually to be a lot easier to see than a cholangiocarcinoma. And so sometimes, it's not 100%, but if you can see it really well and it's not hard work, you're just like, maybe this is something else. But the real clue, of course, is in the involvement of other organs. Many of them are associated with autoimmune pancreatitis, which we can see on MRI as well, and many patients have renal lesions. So here's a companion case, is again, a patient with a terrible looking biliary tree. They realized the IgG4 was elevated, gave them steroids. And again, we can see here on MRI, we can just see resolution of pretty much all those findings. So that was about all the examples I had. Of course, there's a lot more that we can talk about in terms of looking at the biliary tree and MRI and other things. And of course, given the opportunity, I'll go on forever. But it is an important tool, and it's really something nice that we have that produces really nice images when we get really nice images. But we can do something without giving contrast, very non-invasively, and we can see it. Now we've got a whole bunch of different ways to do it, and again, you're definitely going to see these when you look at your patient's images. And just kind of knowing what your patients are going to have is really useful. We talked a little bit about cholangiocarcinoma, sort of malignant things. We talked about benign things. We talked a lot about stones, and then primary sclerosing cholangitis, as well as IgG4 disease, which can mimic cancer. There's more to talk about besides this, but I think this was basically was able to fill the hour. So I think we might have a couple minutes for questions. I'm always available by email and in the reading room, and always happy to chat about this stuff. Thanks for inviting me, and thanks for your attention.